Why are you giving me that look?
Oh, the pressure. It's just weird. Don't test.
What's weird?
You're recording with?
Yes. I already asked Dr. Lunger. She said I couldn't get her face in it though. But they're just recording like all the steps because they paid for the kit, so they're want me to see as an example because we're recording the.
So do you want me to explain to you what I've done so far?
Sure.
So I don't think you want to see the needle, but we took the anticoagulant.
Yeah.
We put some of it in here. We drew up 8 cc's and we transferred 2 into the chamber that's going to spin the platelets into.
Oh, okay.
So the blood doesn't clot together before we get it injected.
Okay.
So that's where we're at right now. Now we're going to draw your blood with what's left remaining in this syringe, okay?
Okay, so you put in both the
syringe,
chamber? Okay.
and then we transfer 2 cc's into the chamber. Okay?
Okay, great.
So go ahead and lay down.
Where are you drawing? You guys are laughing. Where are you drawing from? My arm? Oh my god. So I'm not going to record you drawing my blood because it's just drawing blood and I'll probably pass out, so I'm going to pause this.
Okay. Alright, we'll turn them up.
Okay, so that's my blood. It took 17 minutes to draw the blood, but now it should take only 14 minutes to spin it. I'm just joking. I just want to give them a hard time. Okay, so that's a 60 ml draw, and then she's putting it right there into the
middle chamber.
In the chamber, the PRP chamber.
And when it spins, the platelets and the plasma will be separated into the chamber that we put the anticoagulant in before we started.
That is a lot. All right. So pause that. Okay, so there's my blood on the left with the 60 cc counterweight, and then one push button spin. And I'll check back in. Okay, my blood just finished spinning for the 14 minutes, and let's see how much PRP we got out of it. So here.
These are the needles in the kit that we used to draw back up. Yellow for the plasma.
It's so nice you guys have this stand. It's so much nicer when as opposed to not having the stand. So, all right. So there's. So how does that compare to most 60 ml draws that you've seen? Is that about average, less, more? What do you think?
That's about average.
Okay.
Yeah, depending on the patient, their diet, and things of that nature. This is what we draw first. This is just the plasma. It's about the normal amount.
Yeah. We'll get her face in it, but not yours, Dr. Lundquist.
Close up so you can see like the platelets.
Yeah, absolutely, because I want to see the washing of it. So
the
yeah.
thick white on top.
Let me go from that. Can I twist it a little bit?
Yeah.
Just because, there we go. Because not I had red on red, so I couldn't tell.
Yeah.
So yeah, okay.
So you see the thick white platelet line right there? Yep.
So the buffing coat.
Mm-hmm.
There it is.
They did it already?
They drew, well, not yet. They drew the blood, and then they spun it. So then that's the PRP right there.
Oh. So now we just draw it back up. Try to kind of scrape it off the sides.
Okay, so you have to scrape a little bit.
Yeah, some of it can stick. And then you're supposed to insert a little bit of it back in.
Okay, so you do, okay, gotcha, okay.
And then you and we're good.
Okay.
And all of it. We're good. We're just going to go get you ready to re-inject.
Okay. So let me, that's it, okay? Okay, so for my 60 ml draw, we end up with about 10 cc's of PRP for the 60 ml draw. So just wanted to show that. So now we're gonna record on my wrong knee.
Why is it up in the air? I'll put it up in the air. Put it up in the air.
I was like, wait. I was like, wait. Trying to get a base later.
Ready? Okay, record it. Ready?
No, it all hurts. Ah.
You're good.
Injected. So we're going to do a view of my knee.
That's it. Alright.
Oh, can I lean up? Because I'm going to do...
I don't know. I don't play with this table very often.
So what Dale's doing now is we're reviewing my... Garcia. We're ultrasounding my leg to confirm where the tear is. Well, I know that it's recording on there, but will I be able to pick it up on my phone right here?
Oh, yeah.
All right, so...
I'll give you a little better picture of it as we dive in here. Alright, we're looking at your patellar tendon, your patella, your kneecap is right here on the upper left-hand side of the picture. Your patellar tendon, about as thick as the finger, running right across down to your shin. And you're going to see the tremendous thickening of your distal patellar tendon. Look how thick it is here, again about as thick as my finger. Look how thick it is down there. So you've got rather prominent tendinitis of the distal patellar tendon as it inserts into the tibia, which you can see on the far right-hand side of the screen. And that's because you've just got the big overuse injury there. Soccer for how long, man? You started when you were like 5 years old or whatever.
Yeah, just never stopped.
Yeah, this is prominent. This might actually. Have you slowed down playing since I saw you last?
A little bit. I've been taking it easy on just my compound movements and that on my the pounding thing. I really try to. Well, I've been playing softball too, but I limit what I do at the gym. I just do like light weights, do like range of motion.
Term now?
YouTube prolotherapy, and there's this guy that does prolotherapy. I mean, it is brutal. He doesn't numb. He's going in with the needle, and it's horrible. Yeah, that should.
Maybe you can go a little more bend in you.
Oh, I can't see anything.
Sorry, there you go. Right there. Yeah.
So that's what's going. The PRP is going into the sterile cup.
There's some people that don't do this because you could potentially disturb the platelets, but you have to be really. We're just really good at it, so we're okay with it.
Okay, because when our training, they had said that it goes straight from the syringe.
You can do that. I just never wanted to take that risk of infection. I used to be totally okay with that, but now I am not. In fact, I actually think you should be careful.
So you're also a little bit of the white blood cells. What's that?
This is the platelet poor plasma.
Okay.
And it's useful too. So actually, sometimes, yeah, give me a 10 for that one.
Can I turn a little bit with this, Soccer?
Oh, sorry.
Thanks.
Yeah.
So you're gonna use some of the platelet poor as well.
Yeah. Maybe.
Oh wow.
It depends on how bad you actually might not need it, because you but there's some studies to suggest that platelet poor plasma can be utilized for some tissues that it works better. So we're still trying to figure that out. Like for cartilage tissues and annulus and the lumbar spine, that's still to be determined. So I find that obviously the platelet rich is better, but there is still use for that. So I kind of hate to throw it away. But you probably won't need it since we drew up so much.
Okay, so now we're doing it.
Yeah. Now we're going to clean you. Did you clean you?
Yes, I just cleaned them. I cleaned over.
Put a little more bend in again. Just is that good right there?
Yeah, that's good.
So again, insert.
I'm going to
So he's recording us an ultrasound, by the way. So then the ultrasound's gonna pick it up where the needle is. Oh my God! Hold on, I can't record this. I gotta. They applied a cold spray and then the needle, which feels like a sword.
Don't forget to go that way, 'cause that's what we're trying to get is down there.
So what did you do there? Just the lidocaine?
Yeah. I've never heard it called a sword before. Oh, God.
Like a blade. What did you add there?
Just the numbing.
Oh, that's just the numbing.
Well,
I was like, what's the Oh my god, I barely made it, and all I do is the numbing. Okay, so.
It's so funny. We're just gonna wait like about 10 seconds for the numbing to kick in.
Oh my god. Sandy, can you? No, you can't. Okay.
Do you want me to?
Yeah, you can. You? Here you go. Hold on. There you go.
Which
Thanks.
way? This way?
Yeah, do probably that, and then if we get a shot on the window, you can take one there too. Oh, that'd be great if you can go just like that. Yeah.
No pressure.
A little more angle. A little more that way. There you go. Good shot.
Oh my gosh.
Breathe in through your nose, out through your mouth. And you might have a baby girl or boy, but
I might just have to edit that yelling right there. And then you're recording the needle in there?
Mm-hmm.
Okay.
So where's the tear?
Right there. You're
Right there.
right
So
on
I'm
it.
right in it. Okay, good.
Oh!
Good, good, good.
Oh,
Okay,
oh,
that's it. That's it.
Oh my
Okay.
gosh! Oh my gosh! Don't record me! Oh my god! That hurts so bad.
Do you want me to pause it?
Hold it. Video his hat. Video his hat as he's sucking it. Look at that. Right there.
How's the
So where's it?
medial epicondyle? Like how's
Not bad.
the
There's not a lot of enthesopathy. Here's the
There's not?
UCL right
It
there.
really is UCL?
Just kind of eroded. You can just kind of see a little fragmented edges.
He had lateral epicondylitis because that'd be a really good video. You know.
Yeah, and plus
Really
we've seen how it healed. Yeah, way to go, man. What a disappointment you are.
I'll work on.
Jeez. Yeah, would you go home this
turn
weekend
that.
and rip up your radiocollateral ligament for us? For God's sakes.
Okay, so you already got a view there of it?
Yeah.
Okay.
So now she.
I didn't know she was doing that. Like, I was surprised. I was like, wait, something going on? You're recording this? Did you push? Is it recording?
You're so
Cover this.
Through your nose.
Okay.
So there's nothing else. Gosh, I have all these platelets. There's no way I'm going to be able to use them all.
Like I said, I got a bad knee. You can stick me in.
I'm just waiting for it to come. You're in perfect position. Yes, put the hat
So
over
you
here.
got a few seconds here before she goes again.
What am I supposed to warn you about if I feel
Yeah,
wet?
she's coming with the needle right now.
Anything
Here we
into
go.
your fingers.
There you go.
Yeah, any numbing or any
Okay.
Numbness in
anything into your pinky?
No.
No pressure. Am I on it?
Yep.
Okay. Good, you're on it. Good, good, good.
Breathe in through your nose, out through your mouth. We're almost done.
Feels are good.
This is the only.
Here it is.
This is the only area though in his elbow.
Yeah.
Yeah.
Sorry to disappoint, Doc.
Injection going in
I
right
think we shouldn't put the hole down in there. It's too sore. Okay, we're done.
Oh, that was nothing compared to. Oh, there it is. That's a little bit.
No,
We'll put an ice pack there too.
Okay, so you're clear. Thank you. Okay.
That makes sense?
Yes.
Everybody
So-
for you? Keep that on wherever.
The knee is done there. Elbow, somewhere there. And the elbow, I barely felt that, but the knee, because it's a tendon, Dale's. Explain the difference. Why I'm feeling it better again.
Again, tendons and muscles have pain receptors, have sensory neurons in them. Ligaments, cartilage, they have much less so, almost none in many regards. And so you're not going to have a sensation in a cartilage or a ligament that you're going to have in a muscle or tendon because of that innervation of the nerves, the sensory neurons are going to send that signal to your brain. So, hence, no sensation in the elbow compared to the knee.
Okay.